All right, so a very good evening, everyone. So, in the today's session, we will be discussing the thyroid-related disorders, wherein I'll be discussing uh, quickly about both the hypothyroidism and as well as the hyperthyroidism, and following which we will be doing the multiple choice questions on the topic of the thyroid-related disorders. Right. So, the first part of the discussion will be the hypothyroidism. So if you take this hypothyroidism, what exactly is the problem in this particular hypothyroidism is that where there is failure within the thyroid gland to produce sufficient thyroid hormone. Okay. So the thyroid gland is not able to produce sufficient thyroid hormone. And once there is insufficient thyroid hormone synthesis, that will lead to slowdown of the metabolism. Just one second. Right. So that will lead to the slowdown of the metabolism, right? And once there is slowdown of the metabolism, that will affect the multiple organ system. That is what is the problem in case of the hypothyroidism, right? Now, what are the various etiologies that will be causing the hypothyroidism? So the most common cause of the hypothyroidism in India, right? Most common cause of hypothyroidism in India, it is an autoimmune condition, that is Hashimoto's thyroiditis, right? It is Hashimoto's thyroiditis, where you have antibodies which are formed against the thyroid peroxidase enzyme. So the antibodies in case of the Hashimoto's will be anti-TPO antibodies. And these anti-TPO antibodies will destroy the follicular cells and will reduce the thyroid hormone synthesis. The iatrogenic causes will be radiation. Like, for example, there is cervical lymphoma, and you are giving radiotherapy for that cervical lymphoma, right? And if that particular radiotherapy hits the thyroid gland, resulting in hypothyroidism. Or if there is a large goiter, you have done a thyroidectomy, that will result in the hypothyroidism. Then we have the congenital defects, right? What are these congenital defects causing the hypothyroidism is where there will be mutation of the TSH receptor, right? Where there will be mutation of the TSH receptor. Then we have the infiltrative pathologies. What are these infiltrative pathologies? Where there is abnormal accumulation of the protein within the follicular cell, and that is nothing but your amyloidosis, right? And another important etiology is accumulation of non-caseating granuloma within the thyroid gland, and that non-caseating granuloma is nothing but your sarcoidosis. And next is the excessive accumulation of collagen within the thyroid gland, right? That is called as scleroderma, right? That is called as scleroderma, right? Or there can be accumulation of the excess amount of the fibrous tissue within the thyroid gland, and that we call it as Riedel's thyroiditis, right? So this we call it as Riedel's thyroiditis. Okay, so in case of Riedel's thyroiditis, the thyroid gland will be very stony, hard in consistency. So all these are all the primary causes for hypothyroidism. That is Hashimoto's, the iatrogenic causes, the congenital defects, then infiltrative disorders. Then, if you take the pituitary abnormalities, they come under the secondary causes for hypothyroidism. What will be the pituitary abnormalities? That include any pituitary tumor or any pituitary surgery or the infarction of the pituitary. All these will lead to secondary causes for hypothyroidism. Then we have the hypothalamic disorders. These hypothalamic disorders, they come under the tertiary causes for hypothyroidism, where there is decrease in the TRH, right? Where there is decrease in the TRH. Then what are the medications that will be causing hypothyroidism is, number one, the amiodarone. So how does this amiodarone cause hypothyroidism is? This will cause hypothyroidism or the hyperthyroidism also. How it will cause hyperthyroidism? Amiodarone contains the iodine. So it is iodine-induced hyperthyroidism, which is nothing but jod-based dose phenomena that you see in case of the amiodarone. And that is your amiodarone-induced thyroiditis type 1, right? AIT1, that is jod-based dose phenomena. Whereas in amiodarone-induced thyroiditis type 2, it is your hypothyroidism. What this amiodarone does is, the amiodarone will cause activation of the lysosomes within the cell, and this activated lysosomes will cause the destruction of the follicular cells, resulting in the hypothyroidism. So that is your amidrone-induced thyroiditis type 2. So amidrone is one particular drug which is used in the treatment of the arrhythmias, can cause both hypo and as well as hyperthyroidism. And the another important drug is the lithium, which is used in the treatment of the bipolar disorders. Then the other drugs will be interferon alpha, can cause hypothyroidism. Then we have some tyrosine kinase inhibitors which can cause hypothyroidism. So these are all the various causes of the hypothyroidism. So like what are the types of hypothyroidism now? Primary, secondary, and as well as the tertiary. So in primary hypothyroidism, the problem is within the thyroid gland itself. Whereas in secondary hypothyroidism, it is the pituitary failure, right? It is the pituitary failure. Thereby what will happen to the TSH levels? The TSH levels are reduced. Then you take the tertiary causes for hypothyroidism. Tertiary causes for hypothyroidism, this will be hypothalamic failure, right? This will be hypothalamic failure. So because of this hypothalamic failure, the TRH will be reduced, and that will result in the tertiary cause for hypothyroidism. Then I was discussing about the congenital hypothyroidism. What will be the problem in case of congenital hypothyroidism is this is due to maternal iodine deficiency that will cause the congenital hypothyroidism. Or the other etiology for congenital hypothyroidism will be thyroid dysgenesis, where the thyroid gland synthesis or thyroid gland formation does not occur. These are the causes for congenital hypothyroidism. Now, if you take the epidemiology of the hypothyroidism, this hypothyroidism, it is more common in women rather than men, right? And among the various etiologies, what did I discuss? It is the Hashimoto's. That is the most common cause for hypothyroidism in case of the iodine sufficient areas, right? So in those, the most common cause of hypothyroidism in India, it is Hashimoto's. Whereas the most common cause of the hypothyroidism all over the world, that will be the iodine deficiency, right? Now, you take the pathophysiology, you take the pathophysiology that will contribute to the development of the hypothyroidism. So thyroid hormone deficiency, this will lead to decreased metabolism. So BMR of the individual is grossly decreased in patients with the hypothyroidism. That is number one. Second point, there will be accumulation of glycosaminoglycans, and due to accumulation of the glycosaminoglycans, there will be development of what is called as the myxedema, right? And what will happen to the TSH level? There will be increase in TSH level, but this increase in TSH is observed only in cases of primary hypothyroidism, but not in case of secondary or the tertiary hypothyroidism, right? And the another important problem is these patients will have secondary systemic effects. What are those secondary systemic effects? That includes bradycardia, hypoventilation, and cognitive impairment. Why do they occur? I'll be discussing them in detail in the clinical manifestations. Now, let me discuss the clinical features that you will have in patients with the hypothyroidism. So, in patients with hypothyroidism, there will be fatigue, weight gain, cold intolerance. Why? Because of decrease in the basal metabolic rate. And gastrointestinal motility will be reduced. Because gastrointestinal motility will be reduced, these patients will have the constipation, right? And there is no sweating. That is the reason why there will be dry skin and alopecia will be there. And thyroid hormone is the one which will cause the excitation or stimulation of the cerebral neurons. When thyroid hormone is not there, these patients will have decreased activity of the cerebral neurons, and that will result in the development of depression, right? And you have another important CNS manifestation is delayed relaxation of deep tendon reflexes. These delayed relaxation of deep tendon reflexes, this is called as the hung up reflex, right? So this is called as the hung up reflex. So where there will be delayed relaxation of deep tendon reflexes. Next, what will happen to the heart rate? It decreases because thyroid hormone, it has the action similar to that of the epinephrine and norepinephrine. What this epinephrine and norepinephrine does, they will increase the heart rate, right? So same is your thyroid hormone also. When thyroid hormone is not there, these patients will have the bradycardia, right? And there will be hoarseness of voice in these individuals. and puffy face because of the accumulation of the glycosaminoglycans, and memory impairment will be there. There can be dementia. Muscle weakness. What could be the reason for muscle weakness? Because thyroid hormone is required for protein metabolism within the muscle, and when thyroid hormone is not there, protein metabolism does not occur, and that will result in muscle weakness, right? And in severe cases, there will be non-pitting edema also. In severe cases, there will be non-pitting edema as well. So this will be the clinical features that you will have in patients with the hypothyroidism. Now, how will you diagnose these patients with hypothyroidism? You need to estimate the levels of TSH and as well as the free T4 levels. The first thing is you need to estimate the TSH, followed by that you need to estimate the free T4 levels. That is very, very important point. And if you are suspecting Hashimoto's, you need to check the antibodies. What are the antibodies? That is anti-TPO antibodies and anti-thyroglobulin antibodies. That will help in the diagnosis of the Hashimoto's disease. Now, if you take this T3, T4, TSH in case of the various forms of thyroid-related disorders, in primary hypothyroidism, what is that you will notice? In primary hypothyroidism, you will notice that there is increase in TSH, whereas T3 and T4 will be reduced. Whereas in secondary hypothyroidism or tertiary hypothyroidism, everything will be reduced. TSH is reduced. Subsequently, T3, T4 is also reduced. Whereas you see in case of subclinical hypothyroidism, in subclinical hypothyroidism, you will have the high TSH, right? You will have the high TSH, but there will be normal T4 levels, right? High TSH and normal T4 levels. Now the point is, patients with subclinical hypothyroidism, do they require the treatment or not? Okay, so subclinical hypothyroidism patients require the treatment if they are symptomatic. If they are symptomatic, yes, they require the treatment. Or even if the TSH level, if it is more than 10 milliunits per liter, then also they require the treatment in case of the subclinical hypothyroidism, right? Now, what are the imaging studies which are important in the hypothyroidism is thyroid ultrasound. Thyroid ultrasound, it is used mainly in patients with goiter. Mainly in patients with goiter or suspected nodular disease, these patients, they will be requiring thyroid ultrasound. The another important is the MRI of the pituitary. Why? Because in order to rule out the secondary or tertiary hypothyroidism, you need to do MRI of the brain. Then what are the anticipated complications that you will observe in these patients is, in severe form of hypothyroidism, the individual will go into myxedema coma. Now, what is the reason why they go into a state of coma is because of development of hyponatremia. Because of development of hyponatremia, they go into a state of coma. Then, what are the cardiovascular disease manifestations? They will have hypertension, and you know what type of hypertension that is observed in patients with hypothyroidism? It is diastolic hypertension that is observed in patients with the hypothyroidism. And they will have bradycardia. What could be the reason for bradycardia? Whenever there is hypothyroidism, there is AV block that will result in bradycardia. Next is pericardial effusion. What could be the reason? There will be accumulation of glycosaminoglycans within the pericardial space, resulting in the pericardial effusion. And these patients will have infertility and as well as dyslipidemia. Because thyroid hormone is required for lipolysis. When thyroid hormone is not there, the individual will have the accumulation of the triglycerides and cholesterol, resulting in dyslipidemia. And because of this dyslipidemia, these patients, they are at increased risk of the coronary artery disease. They are at increased risk of the coronary artery disease. And neuropsychiatric manifestations that will be there in the form of depression. And very important is, any patient with thyroid related disorder, either you take hypothyroidism or you take hyperthyroidism, they will be having this osteoporosis. They will be having this osteoporosis. Now the point is, this myxedema coma, it is a very important emergency and they require the treatment. So how is that? Treatment should be done in patients with the myxedema coma. It's a severe form of hypothyroidism. These patients with myxedema coma, they present with altered mental status. They will have respiratory depression, right? So they will have type 2 respiratory failure, and there will also be cardiovascular collapse. Right? There will also be cardiovascular collapse. There will be hypotension and cardiovascular collapse will be there, right? And in patients with myxedema coma, what is the treatment that you need to give is, we need to give intravenous T4. We need to give intravenous levothyroxine. And Patients, if they don't respond to intravenous levothyroxine in them, you need to give intravenous leothyronin. You need to give intravenous leothyronin. So that is what need to be given if the patient does not respond to levothyroxine. But only point is, when you are giving intravenous leothyronin, that is T3, the patients, they are at increased risk of the arrhythmias. Right, they are at increased risk of arrhythmias. So whenever you are giving this intravenous T3, you need to do a very close cardiac monitoring has to be done. So this is about the hypothyroidism and its complications. Let me discuss the treatment in patients with the hypothyroidism. So the first line treatment in patients with the hypothyroidism will be levothyroxine, that is T4 should be given. And those individuals who does not respond to T4 alone, in them you need to give either T3 or you need to give a combination therapy of T4 plus T3 has to be given. And whenever you are giving this levothyroxine, that is your T4, levothyroxine should be given at a dosage of 1.6 micrograms per kg per day. That should be the dosage of levothyroxine that we give in adults. But in elderly individuals, whereas in cardiac patients, we don't start full dose. We start low dose because if you start full dose, the cardiac activity increases and that will increase the myocardial oxygen demand. So that is the reason why in patients with cardiac abnormality or in elderly individuals, low dose is recommended, that is 12.5 micrograms to 25 micrograms per kg per day should be given, mainly to prevent the cardiovascular complications, right? Now, coming to the monitoring, once you start levothyroxine, you need to monitor the TSH. How frequently you need to monitor the TSH? Every 6 to 8 weeks after starting the therapy, the TSH has to be monitored. And once the TSH is stabilized, then 6 to 8 weeks is not required. Annual monitoring is required, right? And at the same time, what should be the target TSH? The target TSH, whenever you are giving levothyroxine, should be 0.5 to 2.5 milliunits per liter. This will be the target TSH, right? So this is about the treatment in case of hypothyroidism. Now, let me discuss some special considerations in patients with the hypothyroidism. What are those special considerations? Number one is the pregnancy. The pregnancy, what happens is, there is increase in the T4 requirements. Why there is increase in T4 requirements? That is due to increased thyroxine binding globulin. Due to increased thyroxine binding globulin, there is increase in the T4 requirement during the pregnancy, right? And what is the levothyroxine dose that has to be increased during the pregnancy? So levothyroxine dose should be increased by, right? Levothyroxine dose should be increased by 30 to 50%, mainly to maintain the optimal fetal development. Right? Mainly to maintain the optimal fetal development, you need to increase the levothyroxine dose by 30 to 50%. All right. Next is the hypothyroidism in elderly individuals. See, elderly individuals, they are more prone to drug-induced hypothyroidism, and they require lower doses due to slow metabolism, right? That is very, very important. So hypothyroidism in elderly, please remember, these patients, they require low dose whenever you are starting. And how much is that low dose? You need to start at a dosage of 12.5 to 25 micrograms per day is what you need to give. Then I was discussing about the subclinical hypothyroidism. What did I tell you about the subclinical hypothyroidism? It is the scenario where the TSH levels are elevated, but they will have normal free T4 levels. TSH level is elevated, but they will have normal free T4 levels. Then do they require the treatment? See, if suppose they are asymptomatic, they don't require any treatment. Or when do they require the treatment is, if the TSH level, if it is more than 10 milliunits per liter, right? Or if the individual is symptomatic, right? Or if the individual is symptomatic, that is the point when you need to give the treatment in patients with the subclinical hypothyroidism. right? Now, what are the dietary considerations which are very important in hypothyroidism? See, if you take the dietary considerations, patients, they should avoid, the patients with hypothyroidism, they should avoid the excessive soybean or soy, calcium, then iron supplements. Why? Because these are the substances, they interfere with the levothyroxine absorption. That is the reason why levothyroxine should be given early morning, right? It should be given early morning, fasting state, right? And iodine intake should be adequate. Iodine intake should be adequate. Now, how is the prognosis? If you do early diagnosis and proper treatment, the prognosis is excellent. Now, if you don't treat the hypothyroidism, the untreated hypothyroidism, they go into a state of the myxedema coma, right? Or they go into a state of cardiovascular complications that will be in the form of the AV block. And they can also develop pericardial effusion. And next important is cognitive decline. Because thyroid hormone, it is required for the cerebral neuronal activation. If thyroid hormone is not there, there will be cognitive decline. So this is about the prognosis in patients with the hypothyroidism. And at the same time, let me also tell you some of the recent clinical trials in the hypothyroidism treatment. Now, what are the trials which have been done mainly in the treatment aspect is they have given the combination therapy, right? So combination of T4 and as well as T3, right? And there was a comparison. What was the comparison? To one group, a combination was given, T4 and T3. To other group, T4 alone was given, right? When the combination was given, the combination therapy was safe, right? The combination therapy was safe, right? And it is preferred by patients over levothyroxine alone. But in long term, what has been found was the benefits of levothyroxine monotherapy are inconsistent. The benefits of levothyroxine monotherapy are inconsistent, indicating the need for the further research. So that is about one of the trial for combination therapy, right? Then the other trial was done, the efficacy and safety of armor thyroid compared with the synthetic thyroid. What do you mean by the word armor thyroid? Armor thyroid is nothing but natural thyroid hormone. And where is this natural thyroid hormone derived from? It is derived from the porcine thyroid gland, that is pig. It is derived from pig. So a comparison was done. That is armor thyroid versus synthetic T4, right? Now, presently, the study is evaluating the efficacy, right? Efficacy and safety of armor thyroid compared to that of synthetic T4 in patients with the hypothyroidism. This particular study results are still due, but a study is going on where there is a comparison where one group was given synthetic T4 and the other group was given the armor thyroid supplement. Okay, next. One more important study was the role of metformin. The role of metformin in Hashimoto's thyroiditis. So in this particular study, what they have done is metformin was given in addition to thyroid hormone replacement, right? What this study has shown was metformin may reduce the thyroid antibody levels in patients with the Hashimoto's thyroiditis, right? And potentially offering the additional benefits. That was the study where metformin was added in patients with the Hashimoto's. Okay. Next important was a study was done to check the impact of levothyroxine on the bone density in the older adults, right? So where the older adults were given long-term levothyroxine and the same time the bone density was assessed. When bone density was assessed in those individuals where levothyroxine was given, what was being found was there is increased bone loss in older adults. There is increased bone loss in older adults. Okay. So whenever you are giving levothyroxine in elderly individuals for long term, you need to do monitoring of the bone mineral density. So these patients who had this bone loss, they required calcium supplementation. Okay, and one more important study was done with the help of a humanized monoclonal antibody, right? What was that monoclonal antibody? That is veligotug. Where this veligotug was used? Veligotug was used in thyroid eye disease. What is this veligotug? Veligotug, it is a humanized monoclonal antibody. And this humanized monoclonal antibody, it mainly targets the IGF-1 receptor. It mainly targets the IGF-1 receptor. Okay, so what was the investigation? I mean, what was the trial? Veligotug was given in patients with thyroid eye disease at one group. In the other group, just only placebo, right? What has been shown was, right, veligotug significantly improved the proptosis and diplopia in thyroid eye disease, showing the promise as potential treatment option. So what is this new molecule? That is veligotug. What is this? It's a humanized monoclonal antibody which is targeting the IGF-1 receptor, which is very much important drug in patients with the thyroid eye disease. Okay, so this is about the hypothyroidism and its trials. Done. Now, after having discussed about the hypothyroidism, let me discuss about the hyperthyroidism, thyroid storm, and following that I'll be discussing the clinical based questions. So hyperthyroidism, exactly opposite to that of hypo, there is excessive thyroid hormone synthesis. Thereby what will happen? There will be increased metabolism and increased sympathetic overactivity. Right? Increased metabolism and increased sympathetic overactivity. Right? Why? Because thyroid hormone, it is similar to that of the action over the heart, will be similar to that of your catecholamines. So there will be increased sympathetic overactivity. Right? Now, you need to know the difference between thyrotoxicosis and hyperthyroidism. Hyperthyroidism is the disease, right, where there is increase in T3, T4 levels, and that will cause increase in the metabolism and sympathetic overactivity. Then what is this thyrotoxicosis? Thyrotoxicosis is that, right, where there is excessive thyroid hormone in the body. Where there is excessive thyroid hormone in the body, right? And this excessive thyroid hormone in the body, this is due to the hyperthyroidism, or it might be due to the other causes which are increasing the thyroid hormone levels, that is thyroiditis. Like for example, you take decurvain thyroiditis, there is transient increase in thyroid hormone or exogenous thyroid hormone intake. So thyrotoxicosis will tell you that it is a state of excessive thyroid hormone in the body. Whereas hyperthyroidism, this excessive thyroid hormone is causing increase in metabolism and increase in sympathetic overactivity, right? Then what are the causes? Most common cause for hyperthyroidism will be autoimmune disease, that is Graves' disease, right? Where the antibody is thyroid stimulating immunoglobulin. They will stimulate the follicular cells and they will increase the thyroid hormone synthesis. Next is the toxic multinodular goiter, where it is the tumor which is originating from the thyroid. Next is toxic adenoma, subacute thyroiditis. In this subacute thyroiditis, it is nothing but decurvain's thyroiditis. And in decurvain's thyroiditis, it is secondary to viral infections, right? Secondary to viral infection of the throat. And another name for subacute thyroiditis is, it is also called granulomatous thyroiditis. And these patients with decurvain's, there will be increase in T3, T4 in transiently, then followed by that in the later stages, there will be hypothyroidism. But in early stages, there will be hyperthyroidism. And even if you take the thyroid gland, it is very tender in consistency in case of the decurvain's thyroiditis. And ESR is elevated. And these patients with decurvain's, they present with fever as well, right? Next one is the iodine-induced hyperthyroidism. Iodine-induced hyperthyroidism is what? It is George base dose phenomena. When you give iodine in an individual with the endemic iodine deficiency goiter, that iodine, when it is given in endemic iodine deficiency goiter, will increase the thyroid hormone synthesis. That is what is called George base dose phenomena. And one of the important examples is amidrone-induced thyroiditis type 1. Next is factitious, where the individual is taking exogenous thyroid hormone supplementation, right? So these are the causes for the hyperthyroidism. Now, if you take the epidemiology, among various causes causing hyperthyroidism, Graves is the one which will contribute to 60 to 80% causes for the hyperthyroidism. And hyperthyroidism, it is more common in women rather than men. It is more common in women rather than men, right? The another important is genetics and environmental factors. They play an important role in the epidemiology. And if you take the pathogenesis, it is autoimmune activation of the TSH receptors. That is what you'll observe in case of Graves, right? The another important pathogenesis will be excess thyroid hormone production. Whenever there is excessive TSH receptor activation over the thyroid follicular cells, that will increase the thyroid hormone synthesis. What are the risk factors? Risk factors mainly for Graves. It includes smoking, stress, genetic predisposition, and iodine intake fluctuation, then immune modulating therapy and certain medications like amiodarone. This amiodarone causing hyperthyroidism, it is due to Jod-based dose phenomena, and it is amiodarone-induced thyroiditis type 1. But it is mainly the smoking, stress, genetic predisposition, and iodine intake fluctuations. They are the one which are responsible for the development of the hyperthyroidism. Then, what will be the clinical features that you will have in patients with hyperthyroidism? Because of excessive increase in the BMR in these individuals, they will be having weight loss, heat intolerance, and thyroid hormone will increase the heart rate of the individual, and that will result in palpitations. And one of the most common arrhythmia in patients with hyperthyroidism will be the atrial fibrillation, right? And there will be excitation of the cerebral neurons, and that will excessive excitation of the cerebral neurons that will result in tremors and as well as the irritability. And even if you take the deep tendon reflexes, there are exaggerated deep tendon reflexes. Whereas in hypothyroidism, what is that we have discussed? There is delayed relaxation of deep tendon reflexes, which is called as the hung up reflex, is what we have discussed in case of the hypothyroidism, right? And what will happen to gastrointestinal motility by thyroid hormone? It is increased. In hyper, what will happen? There will be excessive increase in gastrointestinal motility, and that will result in diarrhea. That will result in diarrhea. And because of increased basal metabolic rate, the appetite is increased, but there will be weight loss. And these patients will have the menstrual irregularities. And what are the important signs? They'll have tachycardia, right? Resting tachycardia will be there. And on examination, there will be goiter, right? And exophthalmosis, where there will be protrusion of the eyeball, mainly in patients with the Graves, right? And next is the tremors. Okay, so you ask the individual to outstretch the hand, where you will notice that there will be presence of the tremors. And the diagnosis, it is based on the clinical presentation, thyroid function test, and the autoantibody test, that is thyroid stimulating immunoglobulins. And imaging is needed, right? Imaging is needed. Now, coming to primary hyperthyroidism, the TSH levels will be low, but T3, T4 levels will be elevated. Whereas in subclinical hyperthyroidism, they will have low TSH, they will have low TSH, and there will be normal T3 and as well as T4. And if you take the antibodies, TSH receptor antibodies, that confirms the Graves' disease, right? TSH receptor antibodies that confirms the Graves' disease, right? Next is the imaging studies. Imaging, what is that? Mainly you need to do thyroid ultrasound, mainly to assess the thyroid nodules. Next is the Doppler imaging has to be done. Doppler imaging will show you that there is increased vascularity because of increase in thyroid gland activity. Next is the radioactive iodine uptake studies. So in patients with Graves, there is increased radioactive iodine uptake. There is increased radioactive iodine uptake. Okay. Whereas in thyroiditis, there will be decreased radioactive iodine uptake. Okay. Whereas again, in case of decurvains, there is transient hyperthyroidism. In decurvains, you will notice that whenever there is transient hyperthyroidism, there is increased radioactive iodine uptake again. So this is about the imaging studies that are required in these patients. And what are the complications? Complications, I was saying you, the most common arrhythmia in patients with hyperthyroidism will be your atrial fibrillation. And when the ECG is being done, it will be irregular rhythm, and absent P wave will be there. And osteoporosis, this is observed both in hypothyroidism and as well as hyperthyroidism. Weight loss due to increase in BMR. Whereas in hypothyroidism, we have discussed weight gain, but whereas here it is weight loss. Then these patients will be having muscle wasting. Why muscle wasting? Because thyroid hormone will increase the proteolytic activity, and muscle is made up of protein. So excess thyroid hormone, excessive proteolysis resulting in the muscle wasting. And that too, which muscles are wasted? It is the proximal muscle wasting. Right, proximal muscle wasting. And another important thyroid abnormality will be, complication will be thyrotoxic periodic paralysis. There is increased cardiovascular risk. So that increased cardiovascular risk can be VT, VF, and there can be even sudden cardiac death as well. Right. So cardiac abnormality in hyper will be arrhythmias. Cardiac abnormality in hypo will be pericardial effusion, diastolic hypertension, first degree AV block. Right? And these patients can have coronary artery disease also in patients with hypothyroidism. Right? Now, coming to thyroid storm. Thyroid storm, it is exactly opposite to that of the myxedema coma, right? Where it is life-threatening exacerbation of the hyperthyroidism, where the individual will have the fever, tachycardia, delirium, vomiting, and multi-organ dysfunction. And in thyroid storm, what is the drug of choice? Nasogastric propylthiouracil, right? And followed by that, they will be requiring intravenous beta blocker, that is intravenous propranolol is required. Intravenous propranolol is required, right? Then next important is the supportive therapy. What is it, supportive therapy? Because these patients' body temperature is highly elevated. So they will be requiring the cold compress in order to reduce the body temperature of the individual, right? And these patients with the thyroid storm, right, they will be having the arrhythmias, right? So you need to give anti-arrhythmic drugs if the individual develops the arrhythmias. So this is about the thyroid storm. Now, if you see the treatment of the hyper, right, treatment of the hyperthyroidism. So initially, see, actually there are multiple options. Antithyroid drug is one of the option. Radioactive iodine is one of the option, right? Thyroidectomy is another option. And whenever you are giving this antithyroid drugs, thionomides have to be given. And among the thionomides, methimazole is a preferred drug, except in the first trimester, right? So except in the first trimester of pregnancy, methimazole is the preferred molecule, right? Whereas in pregnancy, in the first trimester, you need to give propylthiouracil. Why? Because methimazole is teratogenic. Methimazole will cause aplasia cutis, right? Methimazole, it is associated with aplasia cutis. That is the reason why in the first trimester of pregnancy, you need to give propylthiouracil. But the problem with the propylthiouracil is it is having a short half-life and it is severely hepatotoxic. That is the reason why in second and third trimester, right, second and third trimester, what is that you need to give? You need to give back again methimazole. Right, back again, methimazole should be given. But whenever you're giving methimazole, you need to do complete bed picture. You need to monitor the complete bed picture. Why? Because it can cause agranulocytosis. And because of agranulocytosis, these patients, they are at increased risk of upper respiratory tract infection. Next, hepatotoxicity is associated with the propylthiouracil. So this is one of the medical management, which is one of the option. Right. Next is the other option for the treatment is the radioactive iodine therapy. So this radioactive iodine therapy, that is iodine 131 should be given. But whereas for diagnostic purpose, what is that you will give? For diagnostic purpose, iodine 123 or iodine 132 should be given for diagnostic purpose. But for therapeutic purpose, what we give is iodine 131. What this will do, this will release the beta rays. This will destroy the thyroid tissue. And that will result in the euthyroidism or the hypothyroidism. That will result in euthyroidism or the hypothyroidism. Okay, but the point is this radioactive iodine therapy, it is contraindicated in pregnancy. It is contraindicated in pregnancy, and it should be used cautiously in ophthalmopathy patients. In Graves' ophthalmopathy, you need to use this radioactive iodine therapy cautiously. right? Now, when will you consider surgery? Whenever there is large goiters, then you need to consider for surgery. Or whenever there is compressive symptoms, there is dysphagia due to compression over the esophagus, or there is wheeze or dyspnea due to compression over the trachea, and there is hoarseness of voice due to compression of the recurrent laryngeal nerve, right? So that is when you need to give or you need to do surgical management, right? And preoperative preparation with anti-thyroid drugs and beta blockers is very much essential. Preoperative preparation with anti-thyroid drugs and the beta blockers is very much essential whenever you are giving this, whenever you are doing this surgical therapy, right? Next is see, we have discussed hypothyroidism in pregnancy. In hypothyroidism in pregnancy, what did we discuss? There is increased requirement of levothyroxine, whereas hyperthyroidism in pregnancy, it requires careful monitoring, right? And in first trimester, as I have said you, methimazole should be avoided. Propylthiouracil is what is given in the first trimester because methimazole is associated with the aplasia cutis. Then hyperthyroidism in the elderly individuals. So elderly patients, they may present with atypical symptoms. What is that atypical symptoms? That is fatigue and weight loss. And that is what is called apathetic hyperthyroidism. That is hyperthyroidism in elderly. So the treatment, whenever you are giving, you should be treat the patients very cautiously, mainly to avoid the cardiac complications. So this is about hyperthyroidism in elderly individuals. Next is subclinical hyperthyroidism. Subclinical hyperthyroidism, like what did we discuss? The TSH will be reduced and T3, T4 levels will be normal, right? T3, T4 levels will be normal, right? And the problem with the subclinical hyperthyroidism is it may increase the risk of atrial fibrillation and as well as osteoporosis, right? And if this subclinical hyperthyroidism is persistent, then they require the treatment. If it is persistent, then they require the treatment. Then how is the prognosis in patients with hyperthyroidism? If you do early diagnosis and appropriate treatment, then the prognosis is excellent. And if you don't treat hyperthyroidism, the individual will go into thyroid storm and there will be cardiovascular disease. And what will be the cardiovascular disease? This cardiovascular abnormality will be mainly in the form of the arrhythmias. Right? This cardiovascular abnormality will be in the form of the arrhythmias. Then at the same time, you need to know the recent clinical trials in the hyperthyroidism treatment. Okay, so we have one monoclonal antibody which has been studied in Graves' disease. What is that monoclonal antibody? That is iscalimab, right? Where a study evaluating the safety and effectiveness of the iscalimab over 12 weeks in patients with the Graves' disease. Over 12 weeks in patients with the Graves' disease, right? So the study aimed to assess the potential of the iscalimab in managing the Graves' disease, right? But specific outcomes were not detailed in the provided source, right? The study is still due, but this is one of the study which is going on. That is the iscalimab. The next important is rituximab, right? So there is one new study which has investigated the single dose of rituximab combined with 1 year of the anti-thyroid drugs. Combined with 1 year of anti-thyroid drugs and improves the outcome in young people with Graves' disease, right? The results have showed that there is increase in remission rate from 20% to higher percentage when rituximab was added to the anti-thyroid drugs. That means along with your methimazole in Graves' disease, if you're adding rituximab, there is increase in the remission. There is increase in the remission. So that is one of the new trial. The another important trial is anti-FcRn therapy, right? That is Immunovant. That is Immunovant. Okay, so Immunovant, it is initiated a late stage clinical trial mainly targeting the neonatal Fc receptors to reduce the IgG autoantibodies in Graves' disease patients, right? And the early studies with one of the similar agent, that is batoclimab, showed over 50% response rates in treatment-resistant patients, right? So in treatment-resistant patients, 50% response rate was there whenever this batoclimab was added as a part of the treatment. So this is one of the new trial. And another important antibody, monoclonal antibody, is teprotumab, right? The other one was the teprotumab. So if you take this teprotumab, it is insulin-like growth factor receptor 1 antibody that was investigated for its efficacy in treating thyroid eye disease associated with the Graves. And the drug showed promise in reducing the symptoms of thyroid eye disease. That is the advantage of this teprotumumab. And one more molecule, as I was discussing this in the hypothyroidism also, that is veligrotug. Right? Veligrotug for thyroid eye disease, it is a condition often linked with the hyperthyroidism. And after 15 weeks, 56% of the patients experienced improvement in the eye swelling, and 32% achieved complete resolution of the double vision. Right? That was the importance in the role of the veligrotug. So if you see the trials, one of the trial was the iscalimab, where the result is not yet there. The other one was rituximab addition along with anti-thyroid drugs. The efficacy was good, remission rate was good. Then the anti-FcRn therapy, right, where 50% response rates was there in treatment-resistant cases. Next is teprotumab, that is mainly for thyroid eye disease. Next is veligrotug, even that is also for the thyroid eye disease. So this is about the trials that you have in patients with the hyperthyroidism. Now, let me discuss the clinical based questions, right? Clinical based MCQs in the thyroid disorders. Okay, next. Yeah, you see these questions. Right, so I want everyone to have an active participation. Please answer the questions in the chat box. So we have a 42-year-old woman with history of Graves undergoes radioactive iodine therapy. 6 weeks later, she develops fatigue, weight gain, periorbital edema. TSH is 35 milliunits per liter, and free T4 levels are low. What is the best next step in the management of these patients? Repeat thyroid function test in 6 weeks, start levothyroxine therapy, perform thyroid ultrasound, administer second dose of radioactive iodine. Yes. So what is the problem here? After supplementing the radioactive iodine, the individual has developed hypothyroidism. So for the treatment of this hypothyroidism, because she developed fatigue, weight gain, and periorbital edema, all these are the features of hypothyroidism. So these patients, they have to be started on the levothyroxine therapy, right? This is post-radioactive iodine hypothyroidism, which the patient has developed. All right. The answer is second option. Next. A patient with suspected subclinical hyperthyroidism has the TSH 0.1 milliunits per liter, but normal free T4 and T3. Which of the following is the strongest indication for the treatment? Strongest indication for the treatment: mild tremors, atrial fibrillation, then increased appetite, goiter with normal TSH receptor antibody levels. Usually patients with subclinical hyperthyroidism, they don't require any treatment. But a patient with subclinical hyperthyroidism, if at all, if they develop atrial fibrillation, that is the point when, so atrial fibrillation, or a patient with subclinical hyperthyroidism developing osteoporosis, right? A patient with subclinical hyperthyroidism has increased cardiovascular risk, increased cardiovascular risk, and older patients or older adults with subclinical hyperthyroidism. These are the group of individuals where they require the treatment in case of subclinical hyperthyroidism, right? Next. Okay. So we have a 55-year-old male with history of multinodular goiter, presents with difficulty breathing when lying flat. What is the most appropriate next step? Right? History of multinodular goiter presents with difficulty in breathing when lying flat. What is the most appropriate next step? Obtain thyroid function test, perform the FNAC fine needle aspiration biopsy, order a CT scan of the neck and chest, start empirical levothyroxine therapy. Yeah. So the individual is having a multinodular goiter and the individual is having breathing difficulty. That means the goiter is compressing the trachea, or the goiter is compressing the airway. So in order to test that, you need to order the CT scan of the neck and as well as the chest. Order a CT scan of the neck and the chest. That is what is the next step that you have to do in these patients. There is a tracheal compression which is happening there. So to assess the extent, before deciding the treatment, you need to do CT scan of the neck and chest, right? And then followed by that, you need to consider surgery or radioactive iodine therapy should be given. Okay, next question. A 38-year-old woman presents with painless neck swelling and fatigue. TSH is low, right? TSH is low. Free T4 levels are elevated and TPO antibodies are positive. What is the most likely diagnosis? TSH is low, free T4 levels are elevated, TPO antibodies are positive. What is the most likely diagnosis in this patient? Painless neck swelling. Right, the TPO antibodies are positive. Graves, subacute, Hashimoto's, then silent or painless thyroiditis. Right. So here, if you observe the clinical scenario, the T4 levels are elevated, the free T4 levels are elevated, then the TSH levels are low, and TPO antibodies are positive. Where do you have TPO antibodies? You'll have TPO antibodies in case of the Hashimoto's, right? But in Hashimoto's, what is that you'll have? You'll have the, what is that you'll have? You'll have hypothyroidism, right? But we have one important scenario that is called as the silent or painless thyroiditis. Painless thyroiditis, this is one of the self-limiting autoimmune condition. Right? So this is one of the self-limiting autoimmune condition. Okay, so this self-limiting autoimmune condition, this presents with, right, this will present with transient hyperthyroidism, right, transient hyperthyroidism, followed by that, the hypothyroidism will be there. Followed by that, the hypothyroidism will be there. So this is what is called as the silent or the painless thyroiditis. Okay, next question. Okay, so a patient with medullary carcinoma, medullary thyroid carcinoma has persistently elevated calcitonin after thyroidectomy. What is the most appropriate next step that you need to do in this patient? Initiate levothyroxine suppression therapy, measure the urinary metanephrines, perform a PET CT scan, then monitor the calcitonin levels annually. Monitor the calcitonin levels annually. Right. So here, even after thyroidectomy, there is persistently elevated calcitonin levels. There is persistently elevated calcitonin levels. That means it is suggestive of metastasis. Right? It is suggestive of metastasis. right? So these patients, in order to check for the metastasis, what is that you need to do? You need to do, or you need to perform the PET CT scan. You need to perform the PET CT scan. Okay. So this is about the next step that you need to do in a patient where after thyroidectomy, still calcitonin levels being elevated. Next, a 28-year-old man is diagnosed with Graves first trimester of pregnancy. What is the initial treatment that you'll be giving in these patients? What is the initial treatment that you'll be giving in these patients? Right. So first trimester of pregnancy, Graves. What is that we have discussed? You need to give propylthiouracil. Why? Because methimazole is a teratogenic. Methimazole is teratogenic. This will cause aplasia cutis in the first trimester of pregnancy. And once organogenesis is over in the first trimester, in second and third trimester, you can give methimazole. But in first trimester, you need to give propylthiouracil because it is not teratogenic. Because it is not teratogenic. Okay. So the answer is C. Right. Next question. A 65-year-old male presents with weight loss, diarrhea, and atrial fibrillation. His TSH levels are undetectable, and there is the free T4 levels being very high. Radioactive iodine uptake scan shows low uptake. What is the most likely diagnosis in these patients? Most likely diagnosis in these patients. So if you take this clinical scenario, what is it suggestive of? This clinical scenario, it is suggestive of your hyperthyroidism. Right? This clinical scenario is suggestive of the hyperthyroidism. Graves is hyper, toxic multinodular goiter is also hyper, pituitary adenoma producing excess amount of TSH is also hyper, thyroiditis is also hyper. But what is the point here? There is low radioactive iodine uptake. So what is the answer here? That is in thyroiditis. Because in Graves, you will have increased radioactive iodine uptake. Whereas in thyroiditis, you will have low radioactive iodine uptake. Right? So the answer is thyroiditis. Okay. Next question. A 50-year-old woman with thyroid nodule undergoes the fine needle aspiration biopsy, which shows follicular neoplasm. What is the next step in the patient? Repeat FNAC in 3 months, perform molecular testing, total thyroidectomy should be done, hemithyroidectomy should be done. Right. So the FNA biopsy shows follicular neoplasm. See, follicular neoplasms, they require the histological examination. Why you need to do histological examination? In order to check the capsular invasion, right? In order to check the capsular invasion, the histological examination is required. And in order to do the histological examination, FNAC alone is not sufficient. It cannot be determined by the FNAC alone. What is that you need to do? You need to do lobectomy. Okay, lobectomy is a diagnostic procedure of choice in case of the follicular neoplasm. Okay, so the answer is D here, right? Next question. A patient with the history of papillary thyroid carcinoma develops new pulmonary nodules. What is the most appropriate next step? PET CT, serum thyroglobulin assessment, empirical radioactive iodine therapy, core biopsy of the lung lesion. Yeah, what is that you want to do in case of papillary thyroid carcinoma? So please remember, in case of papillary thyroid carcinoma and as well as the follicular thyroid cancer, in both of them, right, in both of them, thyroglobulin is a tumor marker. Thyroglobulin, it's a tumor marker for papillary and the follicular thyroid cancer, right? And if thyroglobulin levels are elevated, if thyroglobulin levels are elevated, that will suggest the metastatic disease. Right? That will suggest the metastatic disease. Okay, so the point here is the patient is having the presence of the pulmonary nodules. So what is that you need to do, right? You need to do serum, right? You need to do serum thyroglobulin measurement has to be done. All right, so the answer is B. Next question, last one. A 60-year-old woman presents with severe hypothyroidism, hypothermia, and bradycardia. What is the most appropriate immediate management? IV levothyroxine and IV hydrocortisone, oral levothyroxine and beta blockers, radioactive iodine therapy, TSH suppression therapy. So the patient is having severe hypothyroidism, hypothermia, and bradycardia. First of all, you need to understand this clinical scenario. What is this clinical scenario? This clinical scenario, it is suggestive of the myxedema coma. And in case of myxedema coma, which is a medical emergency, they will be requiring the IV levothyroxine along with that IV hydrocortisone has to be given. Why you need to give IV hydrocortisone? Because the adrenal reserve for the steroid will be utilized in patients with the myxedema coma. That is the reason why you need to give intravenous hydrocortisone. Okay, so the answer is A, first option. Whereas you take second option, we don't give beta blockers when there is bradycardia. Second option is out. Radioactive iodine, it's a treatment in hyper, but not in case of hypothyroidism, right? And the TSH suppression therapy is not useful in a case of the myxedema coma, right? So the answer is the first option, right? So this is about the discussion related to the thyroid related disorders. So tomorrow, at 6 p.m., the discussion will be related to adrenal gland disorders, right? Where I'll be discussing Cushing syndrome, Conn syndrome, Addison's, and then pheochromocytoma. All these four disorders I'll be discussing tomorrow at 6 p.m. Okay, so thank you very much and see you tomorrow at 6 p.m.